Okay. All right, so it's official. We're recording now. This will be saved and will be put up on the community forum on the NeuroCentric Approach Online Course Academy. Welcome to all of you folks on both the Facebook side over here, where we'll be doing the over the shoulder look of the Zoom meeting over here, where the members are gathering now. Let's see, things to talk about today. Just came across my desk that we've had some interesting events in the UK. My wife was just over there. She just walked Hadrian's Wall all by her lonesome from one side of Britain to the other. She's in the air right now from there to here, so I'll get to see her this afternoon. And the other thing that's happening in the UK is the IPL World Powerlifting Championships were in the UK this weekend. And we had a couple of lifters from Kabuki Strength Lab, where I have one of my offices, to show up. And two of our coaches went as well, one in support of one of those lifters. That lifter's name is Charlie Ritchie, and she is now the proud holder of 5 new world records. And she and her coach, Brandon Morgan, are very happy about all of that, of course, as you can imagine. And our other head coach at Kabuki Strength Lab, that's Kyle Young. Kyle is the head coach of the United States Powerlifting Federation team. So he was there in support of the U.S. team. And in team competitions, the U.S. is now, again, the top powerlifting team in the world. So it's going to be buzzing next week at Kabuki Strength Lab, where we will have some interesting gatherings, and we'll all get to touch the new medals for Charlie. I'll talk a little bit about some of the things that showed up in Charlie's training block this past 12 weeks for our case conference today. So Charlie presented, and she's given me leeway to talk about her case and these kinds of things. And we might have her on here in the not too distant future, like we had Coach Kyle on a little while back. But Charlie showed up with new onset of right pectoral pain, bench press. She is a 300-pound bench presser, and as you can imagine, putting that kind of load through your shoulder can sometimes result in some challenges to the muscles there, and sometimes they don't meet the challenge quite so well. So in her case, she felt a pulling in that area, and then it was quite painful for her to try to continue to train under anything over about 225. So did an assessment, and of course did it initially from the NeuroCentric Approach vantage point. When she came in and presented, it was actually painful at that point in time for her just to do a push-up on the floor. So that was our index movement. So I set up an index movement that we could then test against. And then using the NeuroCentric approach, graded neural evaluation. Yes, we talked a bit about her beliefs, the brain-based issues and the history. She felt like she had a pectoral strain. It looked like a relatively uncomplicated pectoral strain. Her cellular aspects, no real changes in diet, no real changes in her systemic health. Although she had been going through a lot of emotional trauma, her doggie had passed away, so she'd been sleeping poorly. So poor sleep, her interleukin-6 levels are going to be higher. So any particular nerve, nociceptive neuron that's going to be talking is going to be talking a bit louder. The firing threshold is going to be reduced on neurology when those kinds of situations have set up. Now, that's the brain and systemic elements that we cull out of the patient history. Then the next place that we go to is the largest caliber neurology and the list next. So that was spinal cord and nerve roots. So I initially just had Charlie lay out supine, and I created some space at the IVF in her spine by doing some manual cervical traction and some mobilizations for opening in the lower cervical spine at on the involved right side. And then had her reproduce her index movement for the push-up, and lo and behold, her pain was about 50% improved after doing that. So then when I went downstream and did our peripheral nerve work, really didn't get any buy-in, challenging using the upper limb neural tension test. So what nerves are the upper limb neural tension test querying? That, of course, is the median, the radial, and the ulnar nerves. So she didn't really have any sensitivity along that line. That was amazingly notable. But then, as those of you who have taken the upper quarter course and learned a bit about the involvement of the pectoral nerves, a reminder that the medial and the lateral pectoral nerves are right in this area. So right now, put a finger on your acromion and then drop medial to the tendon of the pec minor and just inferior to the clavicle. And you're going to be roughly right over the area where the medial and lateral pectoral nerve arise. Now, the lateral pectoral nerve is primarily motor to the pec major, and it also has a little bit of an offshoot to the pec minor as well. So when I get on that particular area, which is not on the muscle, compared to the other side, she was quite tender. So now we're using not tension testing to evaluate peripheral neurology. Now we're using palpatory testing to evaluate the mechanical sensitivity of that nerve, and that nerve area over the lateral and medial pectoral nerves in that area were hot. So if I go relative to the other side, if I went upstream over the brachial plexus, she was a bit hot there as well, but mostly right in that area. So let's talk through why that might happen. Remember the the spinal derivation is C5 to C7 roughly for those particular nerves. And recall as well from our previous discussions that those nerves are arising at the portion of the cervical spine that most commonly suffers degenerative changes earlier, in the same way that L4-5 and L5-S1 in the lumbar spine do. And what are the most common irritants of those particular joint structures? A lot of it is modern lifting, or modern living rather. It's a lot of cervical forward head position over time, especially if you combine that with a head up. And we'll see aggravations of that in desk workers that then go do something with their head up like this in the gym. We'll see it in athletes when they try to eke out that last rep by jutting their head forward, and then they do all kinds of interesting things like that. And one of the ways that we can address that, ironically, is to apply a McKenzie intervention, right? And we'll test retractions, and commonly with those retractions, which, by the way, are also narrowing the neural foramen, commonly the symptoms will get a bit better. And we don't think that that's necessarily because we've biggered the hole for the neural foramen and the involved irritated nerve root, probably irritated because of an osteophyte or a disc locally. But the retractions, and the way I put this to patients is, this is not suggesting that this is a better way for you to walk through the world. I always joke with patients that that's a good way to get dogs to bark at you when you walk around like that. What we think that is doing is it is counteracting this tendency for working on computers. And I know there's papers out there about forward head position and text neck and not really being a thing. But, and perhaps it isn't when you look at a large heterogeneous population, but I regularly with these patients, when we work with them like that, and perhaps like in Charlie's case, we do retractions, and then I'll commonly, against the McKenzie or protocols, I'll do retraction with extension and rotation and see if we can make more room here in the neck and lift them over a sore spot in the cervical spine. And in so doing, we're recruiting extra movement to the in extension to the upper thoracic segments. And now instead of just one or two segments moving at C5, 6 and C6, 7, perhaps we have 5 or 6 segments contributing to that extension moment. And the patient will commonly do 1 or 2 here, and then when they tilt back, it's like, oh, that hurts. But if I then coach them into, this is one of my favorite external cues, I say, I want you to imagine that you're the world's most curious turtle. And by and large, turtles don't consider ceilings very much, but not you. You're the most curious turtle in the world. And I want you to get your head out of your shell and look at the ceiling and try to sniff the ceiling and try to rub your chin on the ceiling. And then I'll give them a kinesthetic cue and stroke their neck and say, feel that stretch right in there. And now wiggle your head back and forth a bit. And as they do that, I'll ask them, are you able to lift over that sore spot in your neck? And if they can't, then this is probably not the time to be doing that. Things are probably inflamed enough in that area that they're not able to get over it. But commonly, they will be able to lift over that sore spot and continue to do that. Now, after that, they've recruited, almost from a regional interdependence perspective, they've recruited upper thoracic T-spine extension. So now I've kind of blended a couple of approaches to get some movement in that area at the IVF. Now, I mentioned that the two most common reasons we're going to have some irritation of a nerve root there at one of those levels is because of either an osteophyte or a disc. So let's develop those ideas a wee bit more. The osteophyte in and of itself is not really an issue. As long as nerve roots, by and large, are pretty resilient to a lot of mechanical stressors. But if you have a person that sleeps in a position, perhaps belly down with their head fully rotated, or a common one that I'll see is falling asleep on a plane and their arm is like this and then their head is like this, and it puts a focal compression on the nerve root for a long enough period of time to disrupt blood flow, disrupt the perfusion, and cause mechanical sensitivity of that neurology. And that is another way we can have it. Another way we can have it is a stinger, like you see in football, where patient's head gets snapped that way. I saw a slip and fall case like that last week, where they landed on an outstretched arm and got their shoulder jammed into their ear. So that's a possibility in a way that an osteophyte can interact with the nerve root. It can also, over time, if it develops significantly enough, it can start to encroach and cause, just with day-to-day activity, some issues there. And that patient might wind up being, if you're not able to create more space with traction, mobilization, and manipulation, if you're not able to create a better environment for that nerve, then it might wind up being a surgical consideration. The other issue, as I mentioned, is possibly a disc, and that disc could present an irritant to that nerve via a compressive mechanism, as we just described. Compress a nerve for long enough, a nerve root as well for long enough to disrupt perfusion, and the nerve will become mechanically sensitive. And when that happens, everything downstream along that neural pathway will tend to be sensitized. Now, here's another one that some of you who have taken my Fix Your Own Back course, for those of you that are on here that are not part of the NeuroCentric Approach Online Academy, currently we've got 30 hours of continuing education on there online, and among that 30 hours is an 8-hour Fix Your Own clinical companion to Fix Your Own Back course. It's also a lovely 13-hour germane to our topic of conversation, a 13-hour Fix Your Own Back for the strength athlete course that's on there, that I did in collaboration with the aforementioned coaches, Coach Brandon Morgan and Coach Kyle Young at Kabuki Strength Lab. And through that, we worked through Kyle's disc herniation, subsequent extrusion, subsequent surgery, and then build back to his first powerlifting meet after the surgery. So it was 18 months after the original injury, and he just competed in his first powerlifting meet just a few weeks ago. Whoop, whoop. Back to Charlie, our other powerlifter right now. Charlie's, if you have a disc which is presenting as an injured structure with subsequent inflammatory cascade, then a local inflammatory cascade near a nerve root from any structure will cause the nerve root to be mechanically sensitive. We know that from James Iatridis's research. His lab, I believe, is at Beth Israel And I cite his work in that Clinical Companion to Fix Your Own Back course. But they did some interesting studies of using tumor necrosis factor alpha, which is one of the first inflammatory cytokines in the inflammatory cascade. And that injection, they would take an injection of tumor necrosis factor alpha and inject it in the area around a nerve root, and then monitor the behavior of that nerve root downstream. And firing thresholds, the action potentials of the nerves downstream would become reduced just as a result of the expression of the tumor necrosis factor alpha. So we can have localized inflammation, perhaps from a strained muscle near the spine, or a strained ligament, or some pull on a joint capsule, or from a disc. And we can have the scenario then for mechanical sensitization of that nerve root, which we might also refer to as a form of radiculitis. Now, how does that play out in our case study? If we don't have compression of the nerve long enough, then it will only be mechanically sensitive. If it's compressed for a bit longer, then we could have the possibility that motor to the involved downstream muscles in the myotome for that nerve root could be affected. And what's our motor? What's our myotome for the lateral and medial pectoral nerves? It's the pec minor and the pec major. And what's our index? Our index is using those particular muscles. So what we generally see, we know this from the research of folks like Eric Zucodny. I believe he is at the University of Calgary, that a nerve, when you compress for a period of time and then release and then compress and then release, depending on how severe the compression is and how long the compression is, will determine how the nerve or the nerve root will behave. Compress it for a long enough period of time, you can disrupt axoplasmic flow. That's Jeff Bove's research. And that can cause a local buildup, a spillover at that area of compression of the various ligands and ion channels that are being constructed in the nerve body, or the cell body, and distributed along the microtubules within the nerve for delivery at the nerve terminal out at the end of the nerve. And they, at the site of compression, shown by Bove and his colleagues, I almost envision it as one of those mining car railroad kind of situations, and the cars all spill off, and you have a concentration then locally of those ion channels and such, and they start to inappropriately get inserted on that nerve at that area. And then at a node of Ranvier, or if the myelin has been damaged in that particular area, then we have the setup for something that looks like what David Butler called an abnormal impulse generating site, an AIGS, or as is also referred to in the literature as an ectopic generation point. So that's one thing that can happen locally. If the compression is intermittent like that, but we don't have the presentation of an AIGS, then downstream that nerve behaves almost like a light cord for a lamp that has a short circuit in it, and periodically you have a pulse of action potential. And there we might have the presentation of fasciculations in the muscle. So imagine a scenario then. I could create I think, a relatively compelling narrative here. Again, keeping an eye on my biases or trying to, wherein that lifter in a bench position might be pressing their head strongly into the back of the cushion as they're taught. And in so doing, with that strong retraction and trying to get that arch in the thoracic spine, we create an environment of a narrowed neural foramen, which could then cause temporarily that fasciculation in the downstream myotome, the pectoral muscles. So imagine the force curve through a pectoral muscle going through a bench press with very heavy load, when the neural input to that muscle, the motor input to that muscle, is hiccuping. That creates a lovely environment for a muscle strain. I see that in runners, or think I see that in runners, if my narrative is correct, with calf strains, where they've got some sort of low-grade upstream radiculitis from the lumbar spine, and then they go out. Commonly, those runners will run first thing in the morning, and they roll out of bed, get their clothes on, and they might do a little bit of rounded back stretching of the hamstrings before they hit the road. And that first hour of the day, that disc is plumped up and is a little more puffy. So it's got greater hydrostatic pressure on it, and it's a little more prone with a combined compression and additional flexion to put a compressive load on that nerve root, perhaps causing that little fasciculation kind of tendency in the muscle. And then they take that calf muscle, the soleus typically seems to be the one that I find most commonly affected there, out on a run, and they wind up with a soleus strain while they're running. So that's what I think I'm seeing with these. In this particular case with Charlie, we doubled down on the neck intervention. I gave her some more traction, and then we saw each other relatively close together for a few days doing traction. And at home, she was working on the MDT retractions and the retractions with extension and rotation. And I also put her on the thoracic spine extension and rotation and quadruped movements, and had her doing those several times daily, and certainly before her training session and as active relief in between her lifts. And she was able to get back out and continue training. Still hurt, and she had a point where within each training session where she had to kind of call things off and not continue to irritate those structures. But we were able to take enough of the heat off of the involved neurology to get better behavior from the nerve to continue a training effect. We also use some of our cool equipment at Kabuki Strength Lab for things like this, using a Cadillac bar, which many of you have seen as a bowed bar that has a variety of hand grips, both close together and further out. They essentially give you a bit of a neutral grip rather than an overhand grip on a straight bar. So that alters the training load in the muscle. So we're able to lateralize just a bit by using some of the equipment like that and still keep a training effect going. Net result, as of yesterday, we have 5 new world records, and one of those was on bench press. So I'm pretty pleased with the way things went in all of that. So I am here for you guys to continue this conversation if you like, or if anybody has any questions. I'm happy to answer them, but that's our case study for today. We've got a thin population today in the Zoom conference. It's like a cloudy day outside. It's some beautiful fall weather this week, though. But I am here for you guys over on Zoom as well. If you're on Zoom and you haven't joined us yet on the NeuroCentric Approach Online Academy, it is continuing education courses for this approach, the NeuroCentric approach. We've got about 30 hours of online continuing education right now. Dr. Justin Dean and I also teach these courses in an in-person environment as well. Those are 12-hour courses, one 12-hour for the upper quarter and one 12-hour for the lower quarter. And those are available in the near future as we start to book courses, as all of us come out of our collective COVID holes and hopefully don't go back down in one for this winter. But in the meantime, you can get started over there for a variety of different plans. We have a monthly amount that will give you a full access to all of the coursework that's there for as long as you're a member. So you can just pay the dirt cheap monthly amount. Right now it's $39.95. I'm thinking that I am probably going to start slowly increasing the cost, both of the monthly and also the annual amount. The annual amount is $399. So again, you're paying $399, and for a year you get access to 30 hours of continuing education. But in all likelihood, when I take the monthly amount up, the annual membership is probably going to go up by $100. So I'm likely this week, I'm considering taking the annual membership up to $499 as well. Those of you that were savvy and you jumped in when we had the initial offer for lifetime membership got a one-time payment for life for $499 for everything that is currently on the site and everything that we will have in the future. And being a lifetime member also gets you $100 off of the any live course that we teach in the future. So that's kind of a no-brainer as well. So that lifetime membership will probably never be $399 again, but it's probably going to be offered periodically. We'll keep you guys guessing a little bit there for specials as a $499 lifetime membership, and you just pay one time and you get access to us on community, our community forum online. We get questions answered, and eventually this Facebook thing will go away once we get the community large enough that we've got something that's self-sustaining there. Then we'll just move to the Zoom environment and we'll do that. So does anybody have any questions over here in Facebook land? I'm looking for comments here. Those of you on Facebook, you can look. There should be a link available here on the live posting for the NeuroCentric Approach Online Academy. That's academy.neurocentricapproach.com. You can go there and trial the site. Hell, you can try it for free. There's a knee course on there, and it's an hour of free CE. And did I mention that the continuing education that's there is also accredited by PACE? I am a PACE accredited provider of continuing education for chiropractors. So in the US, that's the largest accreditation body in the US. And most of the states in the US will accept CE from PACE. And you can check the Foundation for Chiropractic Leadership Board, FCLB, or PACE online or PACE online, and see if your state qualifies in all of that. Okie doke. So I'm not seeing any questions. That's our case study for this week. I hope you guys have a wonderful weekend. Get out there and enjoy it, and get some case questions for yourself. Bring them for our conference next week, and we'll be happy to troubleshoot and geek out with you then. Take care. I will see you next week.